In this video, we'll discuss laboratory finding in Crohn's disease. What are the features of endoscopy? Endoscopy in Crohn's disease shows number one, rectal sparing, because rectum is often spared in Crohn's disease as opposed to ulcerative colitis. Number two, endoscopy shows after ulcers, fistulas, skip lesions. And what is the therapeutic use of endoscopy? Balloon dilatation of the stricture of less than 4 cm can be done with endoscopy, but the contraindication is acute inflammation. Balloon dilation in acute inflammation may cause perforation. Now, colonoscopy in Crohn's disease. So what colonoscopy does? It does examination and biopsy of the mass lesion, strictures, and biopsy of the terminal ileum. Number two, balloon dilation may also be done by colonoscopy. So balloon dilation may be done by endoscopy and colonoscopy, not done in acute inflammation. Now, virus capsule endoscopy. Barium capsule endoscopy is now replaced with a camera. So this capsule endoscopy visualizes entire GIT and diagnoses the disease better than CT and MRI. So the capsule containing a camera is taken orally or ingested. Camera takes the pictures of the digestive tract while passing through the different parts of the GIT from esophagus to the anus, and finally it's expelled out. So what are the complications of this capsule endoscopy? The most common complication is capsule retention in about 1.4% of patients. And what's the contraindication of capsule endoscopy? Is suspected obstruction, stricture, or fistula. So capsule endoscopy is done with a camera in a capsule, and it visualizes entire GIT from esophagus to the anus. Finally, it's expelled out and may be retained in few cases. And the contraindication to capsule endoscopy is obstruction, stricture, or fistula. So what are the radiologic findings? Early radiologic findings are thick intestinal folds, cobblestoning, and aphthous ulceration. And in advanced disease, there occur stricture fibrosis, fistula, inflammatory mass, and abscess. Now, CT and MRI enterography done with oral and IV contrast and with enteroclysis. They identify active small disease or active small bowel inflammation. MRI shows better soft tissue contrast and it avoids radiation exposure. But CT is done easily and it's available at many places. So CT and MRI enterography are done with contrast and enteroclysis, and these identify active small bowel inflammation. MRI show better soft tissue contrast and it leads to less exposure to radiation. Now, serologic markers of the Crohn's disease. ASCA, Saccharomyces cerevisiae antibodies, are positive in 70% of cases of Crohn's disease and about 10% in ulcerative colitis. Whereas ANCA, anti-neutrophil cytoplasmic antibody, they are positive in 70% of cases of ulcerative colitis and 10% in Crohn's disease. So ASCA is more important as a serologic marker for Crohn's disease and is positive in about 70% of cases. Other tests are antibodies to E. coli protein, Pseudomonas fluorescens, and anti-flagellin antibodies. They are positive in 50% of Crohn's disease patients. So the serologic markers for the Crohn's disease are ASCA and antibodies to E. coli, Pseudomonas, and flagellin antibodies, positive in 50% patients. Patients positive for all 4 immune responses, that is ASCA and antibodies to E. coli protein, Pseudomonas, and anti-flagellin antibodies, have aggressive disease and they have early perforation. So the importance of the immune responses is that if all 4 positive, then the disease is aggressive and their chances of early perforation are more.